So a patient just had successful EVO ICL surgery. They're thrilled, they're excited about what their vision is going to be like. One of the questions we often get asked is, what is the postoperative management and care like? What is the postoperative routine like? And thankfully, it's pretty straightforward with the EVO ICL. It's not that different from a patient who's had LASIK or PRK or even cataract surgery. We see patients on a timeline of a same-day visit, a one-day post-op, and then typically they have a 1 week, 1 month, and 3-month post-op visits as well. Just as with any other post-op visit, we're very attentive to the patient's vision and their pressure, but something that's a little unique about the ICL is because it's an additive lens implant, we actually are also gauging how is that ICL sitting within the eye, and that's something we refer to as vault. And so when you're seeing a patient for that 1 week visit, that's something that's very important to consider. And so could you maybe just talk a little bit about when you're seeing a patient, how do you assess vault?
Yeah, so the EVO ICL is a small, very thin contact lens that's implanted in the eye, behind the iris, in front of the natural lens of the eye. And it has 4 kind of legs that sit in the sulcus under the iris and vaults away, the optic, the center part of the ICL vaults away from the natural lens of the eye. What we want to see is just enough space between the EVO ICL and the natural lens of the eye to allow for circulation of the aqueous through the port of the ICL and around the natural lens to provide nutrients to the natural lens, and that there's not any touch of the EVO ICL to the lens. But we also want the vault not to be too high that it could cause potentially narrowing of the angle and blockage of the aqueous circulation through the trabecular meshwork. So how do you assess that? What you want to do at every exam when you see a patient who has had the EVO ICL, whether it's the first day post-op or a week after, month after, or during your annual exam, on the slit lamp exam, what you want to do is thin the slit beam and angle your light at about 45 degrees while you're looking straight on. And when you're looking at the eye through the pupil, what you will see is with the light shining onto the EVO ICL surface, you'll see the EVO ICL and then focus in a bit more, and what you'll see is a space between the EVO ICL and the natural lens. And that space is kind of a darkened shadow because the EVO ICL will catch the light much the same way that a natural lens that hasn't developed cataract will, and has kind of a whitish grayish tone to it. But the space between the EVO ICL and the natural lens will be a slightly darker shadow. What you want to do is then measure the thickness of that space and compare it to the thickness of the patient's cornea. So typically what we do is then we focus back and forth from the cornea onto the ICL and the natural lens, and kind of go back and forth and create a photographic memory of what the thickness of the patient's cornea is and compare that to the vault being that space between the natural lens and the EVO ICL. And what you want is that vault to be about half the thickness of the cornea to about twice the thickness of the cornea. So somewhere between 250 microns to about 2 millimeters, if you consider a corneal thickness being about 500 microns. If it's any less than that, or if you see a touch to the natural lens, it would be important for the surgeon to be aware of that. And if you see the vault being more than twice the thickness of the cornea, again, please inform the surgeon. Another kind of quick pearl on how to assess the vault: when you see that central port to the EVO ICL, you can shine the light through that port. That'll be an easier way for you to know exactly where the EVO ICL is, and then be able to assess the vault that way. You'll have a really wonderful way to describe that too. Do you want to touch on that or add to?
Yeah, I think sometimes, especially if you're not used to looking at a lot of patients who've had ICLs, sometimes the ICL seems to blend in with the natural crystalline lens. It can kind of be hard to tell what's what. The central port, I think, is like a cheat code now. It's so easy. You look at that slit beam coming in obliquely as it hits the central port, and you will see it cast a shadow on the natural lens. And then that space that the shadow occupies, that's the patient's vault.
I've been told sometimes by doctors who have looked at that central port wondering if it's a bubble in the lens, but in fact, it's a port, an opening for the aqueous circulation.
Yeah, and so assessing the vault is thankfully something that can be done even in an undilated state. But something else that sometimes can be important, hopefully not, when you see a patient, hopefully they're seeing great, but sometimes if a patient had high astigmatic correction, we'll use a toric ICL. And much like a toric IOL for cataract surgery or refractive lens exchange, there are marks on the ICL that tell us exactly how it's sitting within the eye. Thankfully, those marks are a little bit more central on an ICL than they are for an IOL. But let's say a patient comes in, they're a week or a month out, and all of a sudden they were seeing great, but now the vision's kind of blurry. You check their manifest refraction, they have some astigmatism. It could mean that that toric ICL rotate a little bit. Typically, this is quite rare, but sometimes we'll see it if the vault is maybe a little shallow and maybe that ICL just needs to be sized up. In that case, please send the patient back to us. We'll take a look ourselves. We'll assess how that ICL is sitting, and then if we need to, reposition the ICL. That's a very quick fix to easily do, as is if we need to exchange it up for a size that's a little bit larger.
That's usually an issue that may come up early after surgery. Again, this is a refractive surgical procedure, so you want to assess the patient's refractive error. If there's any residual refractive error, do let us know. And as Arjan was mentioning, if the patient had astigmatism to begin with, a toric ICL will probably be used. And early on, when the lens is still not yet fully settled in the eye, there is a risk of it rotating that will manifest with a refractive error of astigmatism.
Yeah, so great point. And so at the post-op visits, again, we're assessing vision, pressure, and the vault. Early on, patients, especially who are not presbyopic, they may complain of their near vision maybe being a little bit weaker. Once the dilation wears off, certainly by the time you see them for the 1-week visit, they should have their natural accommodative capacity back. Remember, we're not removing the natural lens in the eye, so the ICL is an additive procedure, so they should still have their near vision. But if they reach out to you and say, gosh, I feel like my near vision's blurry in the first few days after surgery, rest assured that's quite normal. Now for a presbyopic patient, they may not get that same level of near vision they had beforehand, but that's usually a conversation we'll have with patients and a discussion will be made about should we pursue monovision or not. And so we hope that these key points will make it easier when you see post-op ICL patients. And as always, if there's any questions at all, we're available 24/7. We love managing patients with you. Just let us know if there's any issues.